easy to remember, much easier for people to be aware of. 911 for a certain emergency and 988 for crisis and for suicide experiences as well. 3 parts or 3 pillars of 988, and each of the pillars is just as essential as the other. A place to call, a person to respond, and a place to go, all as somewhat of a catch-all on this continuum, so you can get people where they need to go, keep them out of ERs, keep them out of hospitals, and keep them out of incarceration, when mental health is really what the key is to what they're experiencing.
Welcome to Normalize The Conversation. I'm your host, Francesca Reicherter. Today, I'm joined by Elan Javanfard, a licensed marriage and family therapist, Crisis Services Director at D.D. Hirsch Mental Health, board member of the Crisis Residential Association, adjunct professor, and trainer in dialectical behavioral therapy. The 988 Crisis Lifeline is changing how we respond to mental health emergencies, providing a compassionate alternative to calling 911. Elan explains 3-part system: a place to call, a person to respond, and a place to go. Learn when to use 988, how it helps divert unnecessary hospitalization, and why understanding this lifeline is essential for anyone navigating mental health crises, personally or professionally. If you or someone you love is struggling, this episode shows how help is closer and more compassionate than you think.
Elan, thank you so much for joining me today. I'm very excited for this conversation. But before we begin, I want to check in. How are you really?
Good. I am, depending on the day of the week, the answer to that question may vary, but it's a Friday, and I don't work on Saturdays at all, and I get the opportunity to rest, recover, restore, and work on my resiliency. So
Love that.
I'm glad the week is almost over. So I'm cautiously good.
I love that. It's so important to have that time to rest. That's something I haven't quite mastered yet. A lot of times we just keep going and going until we hit that point of burnout. And I know for me, it's a lesson you think I would have learned by now, haven't. But we just keep going. And I know for me, that was a big thing with my mental health. And I've had to learn how to check in with myself a tiny bit more, because I kept going till I ended up in a psych unit, just putting all this pressure on myself, not stopping, not taking time to just rest and reset. And back then, I also didn't know there were resources available for those moments. So I'm really excited for our conversation today, because we're going to talk about 988 and the 988 continuum, because it's something I needed to learn a lot more about before ending up in hospitalization.
Totally. I talk about this frequently with my staff. I talk about it frequently with clients when I work with them as well. But we need to be mindful of the micro self-care moments and the macro. And I think like society thinks of self-care through macro lenses, like make sure you take vacations, make sure you do all of these big things, or find balance in your work week, take time off and whatever it may be. But like these micro self-care moments are more what it's about. Like on a day-to-day basis, do you have your favorite beverage in hand? Do you have it accessible? Do you have these small things? Do you take 10 minutes between one meeting and another meeting? Do you take time to check in on yourself? Do you set intentions for each day? So that you have these like restorative moments. Do you remember to just breathe or schedule time for taking care of yourself throughout the day, like eating a meal or just taking a moment to schedule a cry or an anxious moment as well? Those micro moments are really what allows people who work in this field sometimes to also make it through, because we ourselves can experience vicarious trauma and burnout from the things we do and from the things we hear from other people.
Yeah, it's so those micro breaks. It is so true. We think it has to be these really big things. And I've started to learn a little bit about ways to just add a minute, 5 minutes, 10 minutes, 30 minutes where I can. So on a day like today, where I podcast record, I used to go back to back 3 to 4 episodes with no break. And now on my calendar, for example, I have 30-minute buffer times already scheduled in naturally.
Mhm.
So nothing
Mhm.
can go back to back anymore. And I at least have time to just take some deep breaths, stand up from the chair, stretch my body, decompress if it was a difficult conversation. And it's really made such a difference. And it's just those small things, that little 30-minute break makes such a difference in my energy levels as I show up for more and more conversations. And then at the end of the day, when I either show up for myself, my friends, or just my dog.
Yeah, and what's so interesting, and it leads to a little bit of what you were discussing as well, is that so many people who struggle with those micro self-care moments are ones who start to experience what we would define in the crisis field as vulnerabilities that led them to their crisis. That like had a person been, yes, the person may be experiencing depression, they may be experiencing insecurity, they may be experiencing some kind of loss or lack of a privilege or some kind of situation. And at the same time, there were so many vulnerabilities that may have happened before that, like they weren't eating 3 meals a day, they weren't trying to get to sleep on time, they weren't taking care of their body, they weren't taking care of their mind, they were overworking themselves or overburdening themselves and under resourcing themselves. Like all of those are the factors that we look at as vulnerabilities before we even look at the individual in acute crisis, because the crisis is something that may have happened, but the level and to the extent that it deteriorates the individual is going to be predicated on how many vulnerabilities led them to that moment as well.
Absolutely. And that's something we often ignore. And there's just such a culture of fake it till you make it, keep going, push yourself harder. It's going to be worth it in the end. The work is worth it. And like the work can be worth it, but you're also worth it. And I don't think there's that balance in conversation. So we think we have to just give up and sacrifice sleep, sacrifice our social life, sacrifice ourselves, skip meals so that we can have that one extra client that day or do that one extra thing, give up just all these pieces of who we are and what we like to do so that we can produce enough to consider ourselves valuable and worthy based on what society has taught us. And when we can learn to undo that just a tiny bit, we can see, at least for me, I could see how much of a difference it made in the intensity. I mean, I still have my depressive episodes. I'm still not great at my self care as well. But the intensity I notice and the length of time is so much lower when I am making those moments for myself and not valuing myself just on productivity.
Right. Yeah. And and taking the mentality, I mean, I think it's my favorite Peloton instructor who says self-care is never selfish. That idea that like if you know, we hear it on an airplane all the time as well, please, you know, secure your mask of oxygen before you secure others, or the idea that you can't pour from an empty cup. All of these are cliches and things that we say in society while simultaneously also telling people they need to work harder, they need to do more. And like we put these platitudes out there, but we don't set up tangible opportunities and tangible steps for the people to actually achieve those platitudes. And oftentimes that's what leads to people falling through the cracks. It leads to people struggling, not knowing where to go, not knowing what to do, and looking for resources or looking for a lifeline of support when they're experiencing or in the throes of crisis.
Yes, exactly. And that do more, be more, that's a thinking trap I fall into a lot. Just last night, I was like, I was being my usual self and just looking at all the things that I tell myself I should have done by now and I should be by now. And then it's just these tears of be more, do more, what's wrong with you? And it takes a lot to like sit back and like, no, I've done a lot with where I'm at and I'm proud of that work and just letting that be enough. And in moments like those, I feel so grateful for knowing what I didn't know 6 years ago was it didn't have to be the ideation or the severe depressive thoughts and the questioning my self-worth by myself or in a psych unit. There was so many steps in between. And I'm so grateful now to not be in that same space where I thought it was one or the other.
Right. Yeah. Thinking that something is a binary choice or it's a black and white. is such a common cognitive distortion people experience in depression. It's something that's talked about frequently within CBT, cognitive behavioral therapy. It also speaks about what you just mentioned before, the shoulds. We in CBT like to say, stop shoulding on yourself. Um, and helping people identify, that that's a distortion of thinking that is being predicated on unhealthy thinking or unhealed wounds that a person is experiencing. And oftentimes that results when people don't have a lifeline or a resource to reach out to who may be able to give them an alternative to being in pain or being in the hospital, which is really the entire inception of the idea behind the 988 continuum, is to that people can be more aware of other options that are available to them besides for staying silently in pain or being in an inpatient unit.
Yeah, exactly. And I remember when 988 was starting to finally, when the phone number changed from 1-800-273-8255 to 988, we saw a lot of people willing to reach out for support for the first time
Mhm.
and learn like there's a place that I can call that I can get support and I don't have to go. And they're not going to just tell me to go into a psych unit. There's going to be other options. And I
Right.
think that was a big shift in mental health care.
Yeah, a large part of it. So, like a little bit of a history lesson for all of us. 2022 July, the number officially switched, and 988 is now the suicide and crisis hotline. So it's easy to remember, much easier for people to be aware of. 911 for a certain emergency, and 988 for crisis and for suicide experiences as well. But what was unique about this, it wasn't just a number change to make it more accessible for people, was that the idea was that they started finally talking about this like three pillars component of 988, that like it can't just be a place to call. There has to be a little bit more to that. And the way they've kind of identified it is there's a place to call, a person to respond, and a place to go. Three parts or three pillars of 988, and each of the pillars is just as essential as the other, because you can't have the tripod standing up with only two pillars in place. A place to call is the hotline, the national number. You call 988 from anywhere in the United States. You get geotagged and located to a trained crisis counselor. And in most situations, those calls get de-escalated over the phone. No involvement of authorities, no involvement of hospitalization. It's just an ability to de-escalate as needed. But for those individuals who need a little bit more, and maybe they need additional support, and de-escalation over the phone isn't sufficient to give them the validation they're looking for, then a person to respond was the idea of having a mobile crisis team. So not police, don't send police out when it's a mental health issue. They can be dispatched into communities. These clinicians, peer workers, peer advocates, or just specialists have been trauma-informed, trained, culturally responsive, and they go out and they meet you where you're at in your crisis, and they help you, giving you that touch point of validation and support. And in cases in which that person needs additional support or additional layers of treatment, but still hospitalization is not warranted, or maybe you want to divert them away from a hospital because a hospital is not the most lovely place for a person to have to stay, there's that third part, which is the place to go, which I am most passionate about, and transparently for your audience as well. It's where you and I have bonded a little bit, because you've been coming out to visit our place to go at D.D. Hirsch, which is called Excelsior House. It's a crisis residential treatment facility where we have individuals coming for voluntary residential treatment as diversions away from hospitalization or incarceration. So like these three elements of a place to call, a person to respond, and a place to go, all as somewhat of a catch-all in this continuum, so you can get people where they need to go, keep them out of ERs, keep them out of hospitals, and keep them out of incarceration, when mental health is really what the key is to what they're experiencing.
It's so important too. Like you said, a hospital is not always the most welcoming place. For me, I know being hospitalized in a psych unit, I I always say I could not imagine a place darker than my brain until I walked through those doors. I mean, the walls were just so, like, I mean, like this, so beige and dark and falling apart. And you were just in a hospital bed where they'd wake you up at 4 a.m. to do blood work, but they wouldn't really talk to you. They would just be like waking you up, doing the blood work, and then walking right out. It didn't feel like there was a lot. There were some nurses and staff members that were so sweet, truly. There were many that weren't, and they're just, it wasn't a great experience to be in the psych unit, just the environment itself didn't feel very good and welcoming. And it felt honestly a bit more traumatizing than the actual attempt and ER and all that component. The actual psych unit part felt worse. And not to tell people that they shouldn't get help if they need help. Please, please get help. There are some psych units that are great. There's also opportunities for diversion as well. But if we can avoid hospitalization when it's possible and when it's helpful and beneficial for someone, I am the biggest advocate for that.
It seems like it's punitive, really. Like you're being hospitalized, and therefore we're going to put you in a punitive situation or a punitive environment. It's the goal of the entire 988 continuum, at least if I'm defining it in like one sentence, in my opinion, is it's stabilization, not institutionalization. Like I love that sentence, and I've heard that from other people, so it's not my own. But the goal is stabilization, not institutionalization. That at any point, if we can catch an opportunity to keep you out of unnecessary ER visits, unnecessary interaction with police or law enforcement, unnecessary psychiatric hospitalizations, we are stabilizing you and giving you the tools that you need to thrive. Because we also know that there's so many different marginalized communities that have historically challenging experiences with the mental health system and with police. And the police themselves, in situations in cities where 988 is thriving as a continuum, they are the most advocate components of saying, like, have more of these places because we shouldn't be the ones to interact with individuals who are actively in the throes of mental health crises. So this component of helping people realize there are other options is so vital and important, because there are people who I've been witness to the sentence, "I'd rather die than be in a hospital." And the assumption there again is binary. It's black and white. It's either one or the other. And when we tell them that there are alternative options, like what if you can go to a residential environment that looks like a college dorm, and you can hang out and do artwork, and you can play, and you can do mindfulness activities, and you can have somebody really nice like Fran come and do art with you on Mondays. Like, what would you choose that over your current home or a hospital? 10 out of 10 people would say yes. And that's part of the awareness that even though 988 has been around almost 3 years now, this continuum is still something that many people aren't aware of, especially these other legs of it. You know, the number people are aware of, but the idea that mobile response exists or crisis residential treatment exists in your communities or your settings, wherever you are in the United States, is something that people are still learning to learn a little bit more about.
Yeah, and that's why it's so important we're having this conversation right now. For those listening who are like, okay, so there's a third option, doesn't have to be hospitalization, but what is residential? Can you kind of break down a little bit about what residential actually looks like?
Yeah. So there are different versions of it. I'll share it out loud up front that I'm biased towards one version because it's the one we operate and the one that I've spent a lot of my career researching as well. But there are several iterations of what 988 would define as a place to go. There is something that's called crisis stabilization units. These are going to be approximately 1 day, 24-hour experiences where people go to in essence, they have like a bed, a chair, a room in a hospital-light environment where they can get stabilization, rest, reprieve, and they can recover. There are other versions that are what we would call crisis residential units or crisis residential treatment, which can vary anywhere between 3 days to the one that we operate, which is one of the longer ones in the country, a maximum of 28 days, where people are living in a home-like environment, a home-like setting. The ones that I visited, the examples that I can provide, for example, Excelsior House, which Dee Dee Hirsch operates in Los Angeles County, it is a 14-bed program. There is a common living room, common dining room area. There are lounging areas for clients. There's a garden outdoors, and there's activities for people to engage in. And then there are bedrooms where the bedrooms are not locked. The facility is not locked. It is physically a house. It's a converted college dorm, pretty much, where there is two people living in a room with their own showers and their own opportunities to take care of themselves. 24/7 a day, there's treatment available. No one is forced to take medication. No one is forced into treatment. There are certain components within billing purposes within any state that will dictate an amount of staff that need to work at any given time. But these staff who are there are plain clothes. They're not dressed in scrubs. They're not wearing a lab coat or anything like that. It's not a sterile environment. It's a home-like environment. Meals are cooked in unison with clients. People sit around the table, wait for everyone to be at the table and eat together. And they get that home-like environment. In most settings, especially in a setting like ours, people are given a few days at a time to remain in treatment, and they're reassessed if they continue to need more time. But at any point in time, if the person feels like it's not for them anymore, the door is open. They can walk out, and they can voluntarily leave, and they're not going to be chased after or followed unless they want permission. And there's an additional model, which is amazing, which is called a peer respite program. So peer respite program is even one step removed from this treatment methodology, where the vast majority of the staff who work in peer respites are individuals who themselves have been through the system or have been through crisis. They're peers treating peers in a home-like environment. They can have meds if they want, but they're not required to see a psychiatrist. They can have therapy, but they're not required to see a therapist. It's just a little bit more run in a recovery-oriented fashion. And some parts of the United States are more open to that, and other parts are learning to be more open to that. But all of them take this one fundamental approach, which is stabilization in a home-like environment is often better clinically and emotionally than an ER or a locked unit. If we can keep you out of locked and you voluntarily choose to be here, then every day you wake up in a voluntary setting that you chose to be in. And I think that home-like environment, and you can speak to it a little bit yourself as well, being and visiting one of these programs as compared to being in a locked unit, is a very different vibe, very different atmosphere and feel. It's like the air feels a little sweeter or a little thicker than thinner in as compared to a hospital.
Yes, absolutely. And that was a big thing when I walked in, is one, like you said, every day you're choosing to get help. You're choosing to get support. You feel like you have a choice. And in a psych unit, I didn't have a choice. It felt like I had no rights, no voice, no choice. And you walk into a place where it looks and feels like a home. A home, for me, a feeling of home is a feeling of belonging.
Mm-hmm.
In the hospital, it's a feeling of I'm their legal responsibility for the next X amount of days before they can just send me off, and that's it. It just made such a difference the first time I walked in. I'm a huge advocate for mental health treatment in any way, shape, or form that helps someone where they're at. Absolutely. It really made me redefine what my expectation of mental health care was, because I saw it really as everything similar to a psych unit model, because that's all I knew. Any place I'd gone and handed out encouragement cards, behavioral health hospital, psychiatric unit. I had never seen an option outside of that. And it was the first time where I was like, wow, imagine going somewhere that creates or cultivates a feeling of home and belonging, not a feeling of you're stuck and trapped.
And I'm hoping and looking forward to you being there and experiencing the opportunity there over time as well, because one of the fundamentally wonderful things that happens is people who've experienced high levels of food insecurity or hoarding of food while they're in a hospital start to realize their meals are coming. There are always snacks available. The holidays are beautiful. People tell us it's the first time they've had turkey on a Thanksgiving, not sitting on the floor somewhere. It's the first time they've gotten gifts, or we give them gifts around the holidays to share with each other. And people like want to stick around or find the sweet spot of how can I be there for Thanksgiving and also Christmas at the same time, or New Year's as well, so that they can have that experience, because they get to decorate. They get to decorate the house. They get to use themes. They get to be seasonal in that way. And many crisis residential programs are really embedded and have become, foundational elements of their communities as well. So they'll take the clients out to volunteer at other places in their area. They'll have give back events with people who live in those communities as well, so that people start to see it not as this, place where we put people and lock them up, but these are individuals who are part of our community, who deserve to be within our community, and we need to involve them in every way we can, because ultimately, when it comes down to it, any of us, including me and you, you take away multiple privileges that we have in our lives, we can all find ourselves back in a situation where we are in crisis too. And if it was up to us, we would rather be in an environment that is home-like, warm, and comforting, rather than in a sterile-like hospital environment.
Absolutely. I'm so excited for the holidays now to get to see this. So for those listening, I don't think I've talked about this yet on the podcast. So for those listening, I go into Dee Dee Hirsch once a week to Excelsior House on Mondays at 1 o'clock. And we do like art therapy, arts and crafts. We make encouragement cards and write letters to ourselves. And it's amazing getting to be part of creating these like tools and this community feeling that I didn't have when I was getting treatment. One thing that I really, really loved and see every week when I go in there is how close all the residents are. They go and make sure if someone's missing, they go and make sure that they grab them because Fran's here to make cards. They will be making, we were playing my like new game, and there is doing it in two groups because the table's long and people weren't hearing each other. And one group pulled a card that said like take deep breaths, and he made everyone stop and take deep breaths together, even though the other side had a completely different card. He was like, we all need to take a deep breath. Like they're really in it together as well. And it cultivates that sense of community instead of, again, my experience being in the psych unit tried to cultivate that a little bit, but everyone was too scared to even really speak. They were like, let's get through this together. And they make cards for each other that I collect, mix around, and then pass back out. And they read the messages out loud from each other. And you just get to see that connection of, thank you for making me that card. That was the message I needed to hear. It's just so different.
And they've become cherished belongings, we've seen and heard from clients. And it's interesting because you're seeing the benefits and the impact the clients are having from what you are doing, and we're seeing the benefits and impact the staff are experiencing from what you're doing, because you're coming in not just as a professional, but you're coming in as somebody who has been there before, has experienced this before, has had to live through some of this yourself before. And the authenticity that you are sharing in the perspective, it's not a forced authenticity. It's a genuine authenticity of like, I've been where you are. I know what your experience is like, and I'm hoping to find a way to help you out. And what really resonates with me is like every time I frequently do lectures at different conferences and events, and there's this story from one of my favorite TV shows of all time, West Wing, that like really resonates with me, and I share it frequently with clients in residential environments. What I tell them is like, story was written for West Wing, but I think it's very useful and a good analogy here. It speaks volumes about you. This person's like walking down this person's walking on the street and they all of a sudden fall into the hole. And the hole is so deep that they're struggling and they can't make their way out. And they shout out at the hole and they see that there is a doctor walking by. And they say, "Hey, doc, can you help me? I'm stuck in this hole." So the doctor writes a prescription and throws it down into the hole for them and keeps going. And they look up and they see that there's like a spiritual pastor, an advisor, or a rabbi walking by and say like, "Hey, I'm stuck here. Can you help me?" This person writes a prayer on a little card and throws it down into the hole for them. And they're starting to get a little despondent, but they look up and they see their friend walking by and they say, "Hey, Joe, I'm stuck in this hole. Can you help me?" And Joe jumps down into the hole. So the guy in the hole says, like, "I don't understand. Like, are you mad? Like, now we're both stuck in the hole." But his friend says, "Yes, but I've been in this hole and I know the way out." And I think that like in crisis residential environments and having people like you come into those environments, like we are ourselves a positive, reinforcing, shaping image of somebody who could have been in that hole or was in that hole and found their way out. But the vast majority of people who work in this crisis field are people who have lived experience. And we have to tap into that lived experience and not just say, go to school, get an education, but like your own experience of having gone through it is just as valuable, if not more valuable sometimes, to catch somebody who's also going through something similar, because you can say, "I've been there and I know the better way out." And that resonates.
That is such a good story. It's so powerful. It's so true. Like I've been there before and here's what's helped me. And a lot of times we don't realize we can take our pain, our stories, and use it to offer that feeling of hope and support to someone else. And one thing I do, and I'm glad that the staff likes it because I'm always like, is this a good idea? I think it is. But I always answer the questions with them. All right. So if it's a group discussion question about when was a moment you felt like shame or guilt, how can you release it? How can you let it go? That's scary to talk about in a room full of people, right? There's a reason you've been silent about it. So it's like, I'll answer it with them and have the conversation. No matter what topic comes up, I'm part of the conversation, right? This is what happened to me. This is what's helped me. Let's get through this together. I make the same encouragement cards with them, and mine gets thrown in the mix, and someone gets one of the cards I made every week. And it just, for me, and I'm glad that it's helping them and the staff likes it as well, it makes such an impact to be part of the journey and not just someone watching it happen and hoping that it helps, getting to really feel it with them. And there was this one resident who had received, because we make cards for future residents as well.
Mm-hmm.
So there was one who had received the card I made. So when that resident had met me, ran up to me and was like, "You're Fran? I have your card. I read it every single day. That's how I start my day. It's how I end my day." This resident, now the last time our group together, Monday, now being discharged before the next time we'd be together. And they had me write a card as well because they wanted another message from me. And just to see that impact of receiving a card from a stranger, not knowing who it is, that helps you get through, and then meeting that stranger, getting to see the humanity behind them, it just makes such a difference.
Yeah. And over time, it doesn't even feel, in a good way, it doesn't feel like treatment. It feels like a family. It feels like it's family looking after family, or it's people looking after people who are in the same shoes they could have been in had there been any other turn in their life. And I think that's the fundamental distinction in terms of trying to create spaces or trying to create more breadth in the country for environments like that as compared to environments that are hospitalization. Hospitals are needed. We need them. But what's more important is we need the right people to use them and have space for the people who actually need them. And for the people who don't, like, a locked setting isn't for everyone. And if we have only locked doors, then people who don't need locked doors are behind locked doors.
Yeah.
And it's never, and it's both of us saying it, it's never our opinion to advocate that we don't need those spaces. Those spaces are warranted, needed, and justified. But let's leave them for the people who can't benefit from an environment like the ones we're describing, and advocating for more residential services, advocating for more of these crisis services. And on the opposite side of this, which is interesting because we haven't talked about it, they cost dramatically less. They cost the taxpayers dramatically less, and the outcomes are better. Like a person's 3-day length of stay in a hospital costs more money to the system than 28 days in a residential environment. And 28 days in a residential environment leads to a 30% decrease in their symptoms as compared to a hospital does. So like for localities or for communities who are like, well, what is this and how can we get it here? Or where are they in our settings? Advocacy related to let's save some money by getting the right treatment in place is also a real big part of this.
Yes, because that psych unit bill was not a fun bill to receive.
Right?
Not fun at all. And then the ambulance bill on top of it, because they had to transfer me from one hospital to the psych unit. Not a fan. It's so much better that we have options to meet people where they're at. And yes, at that point, I did need medical treatment. I probably did belong in the psychiatric unit in that moment in time. I will own that. And I also know that I refused help so many times after that because I thought that was my only option. Had I known residential was a thing, that it wasn't the same as hospitalization, that it wasn't as scary, as expensive, as just feeling of less humanity and less voice, I may have gotten more help that I needed instead of going through so many years of feeling so alone in it, questioning what's wrong with me. Why can't I just like snap out of it?
Yeah. And once a person has been through a more humane and a more safe environment, they crave that and they look for more of that. I'll share with you a story as well that I think is really meaningful. We had a client go through the residential program and do really well several years back. They did really well through the residential program, and they found themselves becoming a peer advocate at a different agency, and got an experience to be an opportunity doing that. And over time, once COVID hit, they lost some loved ones, they lost some family members, they were laid off from that position because they were no longer needed in person anymore. And they were starting to fall back on a lot of the challenges that they had in their life. They were starting to fall back into unsafe patterns and unsafe coping. And what was interesting was that year happened to be the Super Bowl happening at the new stadium in Inglewood, California. The Rams were playing in the Super Bowl. This person was saying that like they were actively using substances again, and they were watching the Super Bowl at a shelter somewhere. And all of a sudden, when the blimp panned out over the city of Inglewood for the Super Bowl, they were like, wait, I know that place. Excelsior House is a block away from there because that's where we're located, a few blocks from that stadium. So in the middle of the Super Bowl, they picked up the phone and they called the intake line and said, like, hi, do you remember me? Like, I want to come back. And just like by visibly seeing the city of Inglewood in a blimp shot, they remembered that crisis residential was available to them, and they found their way back into treatment. And at first there was a lot of shame and remorse as to like, how do I need to be back here? But when they saw everyone there, and when the staff told me this person is coming back, that I made sure I was there the day that they arrived, and it was like, we're all here for you, to welcome you back with open arms. The like tears on everyone's faces, including the client's face, as to like, anytime you need a bed, we're here for you. That was so powerful and so meaningful, and it helped vitalize a lot of the staff who were feeling tired or burnt out and lethargic after the experience of COVID as well. So just knowing that these resources exist in our communities in its own right can be validating and keep people out of the system. That I think is really powerful.
That is so powerful. And it just goes to show how helpful these places are, that somebody can see a reminder that this exists and I can get help again, even if there is a bit of shame, even if there is some remorse, to still know that this is a place that's going to help me is incredible. As we are wrapping up, what's one piece of advice you'd like to leave our listeners with? Maybe it's someone who has been struggling and they thought hospitalization was their only option. What advice can you have for them now?
I think there are a few pieces of advice that I would have for them. One is that you're not alone, and to validate that while you are feeling like you're sitting in that darkness, there are so many other people sitting in the same darkness as you. And the hope is that in listening to this, you identify and hear that there are resources like calling 988, which are not going to be punitive and scary and threatening. And that if you are looking for crisis residential treatment, if you're looking for an alternative to hospitalization, you can call 988 and ask them for resources in your area. You can visit websites like the Crisis Residential Association, which helps champion crisis residential services as alternatives to incarceration or hospitalization throughout the United States. And you can find on a map where those services are located to you. And if you're an individual who's listening to this as an advocate or a peer or somebody who's passionate about this field, find out in your jurisdiction, find out in your local areas, where is the closest one of these Excelsior House type programs to where I live? If my loved one was in need, where is that? And how can I advocate for and champion that these services should be added to the national conversation related to crisis services as well? And if you're ever looking for things or services in Los Angeles, you can always visit the D.D. Hirsch website, and you can always look me up as well to help you advocate for getting into the proper services in LA County and finding the services that are available, because D.D. Hirsch offers services across the board, whether it's residential to outpatient to whole person care and treatment for chronic substance use to mental health concerns. The entire continuum is available to you. You just have to find us and allow us the grace and the opportunity to connect you with it.
Elan, you are amazing. Thank you again so much for joining me today.
Thank you for having me, and thank you for what you do. Thank you for this podcast, the work you do, the workbooks you put out, and also for the volunteering that you do for D.D. Hirsch and Excelsior House. You are truly a crisis champion and crisis warrior, so we're happy to have you in the crisis field.
Thank you so much for listening to Normalize the Conversation. Don't forget to subscribe, rate, and review. This podcast is an initiative of Inspiring My Generation, focusing on normalizing the conversation, bringing education and awareness to the forefront, and amplifying global voices to spark change and hope. Inspiring My Generation is a 501c3 nonprofit organization on a mission towards suicide prevention through awareness, conversation, education, and support. Connect with us on Instagram at Inspiring My Generation and visit our website inspiringmygeneration.org to learn more about our work and how you can make a difference.